we quickly want to have a look at the proposed development of the pharmaceutical package. I know we got, what do you call it? Some members got excited with the students' strike. That has taken a bit of time, but I'll summarize. Won't take the 50 minutes, I think 20 minutes probably, just to save on time, right? So we want to start so that we cover that. So as we've seen with the Ghana, Thailand examples, so I just want to briefly highlight the proposal to look at the pharmaceutical package for Kenya. So we'll just look at where are we now. There are other related work areas. Of course, I think these ones and the beauty is that Dr. Mwai, Dr. Menge, and the other presentation, I think they've really captured a lot of the issues, particularly Dr. Mwai. So I'll spend less on some of the, whatever has been discussed so that we save on time. So current status, other related work areas, the package itself, we won't do the last part, we'll skip that for now. So when it comes to our current status, and I think this is where I mean quite a number of this was already discussed by Dr. Mwai in his presentation, the Kenyan context of, HTA in the Kenyan context. So where are we now? There are so many things to say here, but just to mention a few, we have very high, we have high and varied pricing of HPTs. Cynthia, if you go to public sector, the price is totally, between counties, between levels, prices are different. Then public, private, different, FBO, different, for the same medicine. And I think there was a report actually to this effect by EACC, right? The EACC report quoted that we have a very high variability in pricing across the providers and across sectors, which can be a bit of a challenge. So that's one. Then average availability, we are also varied around that. We have a lot of out of stock HPTs. We also have variability in availability between counties. Some counties for tracer medicine, I think they are as low as what? As low as 25%, 23% availability for tracer. Well, some counties can be as high as 75%. So, and these are all Kenyans, eh? That tells you there's something going on. Then, of course, I think this is what Mwai spoke about. Right now, where we are now for HPTs, it's very implicit. You remember when he talked about, no, I think it is, oh. So do we continue? The security guard has left. There was, oh. Okay. Oh, they're assuming Yeah, so implicit meaning sometimes it's not clear. How the decision and priority setting happens is not clear. Stakeholder engagements are not clear. And I think Dr. Mwai spoke about that. We want to move, part of these reforms is to move from implicit, where it is only NHIF that knows, to explicit, where everyone knows, including the patient. Sindio? If I'm diabetic, is my insulin covered or not? Is my statin covered or not? Is my whatever, like that. What is covered and what is not? It's okay? Okay. So, so I think passive purchasing, we want to shift to strategic purchasing. And I think that came clear from the Ghana and Thailand examples. The Ghana presentation of how they make decisions for their diabetes and trying to improve outcomes while minimizing costs, right? As opposed to saying hospitals will buy. Which medicines? We don't know, right? So, yeah. High out-of-pocket expenditures, I think Dr. Mwai elaborated on this, of which a huge chunk is HPTs. We have a very vibrant local manufacturing subsector. I think the most vibrant in the region. But are we aligning what they manufacture to what we purchase? And are they aligning what they manufacture to what we need? I think there is a lot more synergy. Last time I checked, Dr. Alukana, KEMSA purchases what? Is it 26 or 20-something%? I know there's a 30% local manufacturing target. Where are we? Is it 20, yeah? 20 what percent?
We have to be achieving the local manufacturing because when you look at farms, we are doing about 70%
local. Oh yeah, overall is what comes down because of the non-farms. Eh? Oh yeah, right. So we need to align. That's a local manufacturing agenda for the country. So we also need to align with certain realities around that. Limited data, I think this was discussed. Poor quality, we have a bit of a challenge there. But some of the things we've been doing lead to that. Illegal pharmaceutical outlets, that is a scenario. Sindio? Si siku hizi kila mtu anafungua pharmacy. Yeah? There's a time I closed a pharmacy in Nakuru because it's a long time, but it was a house girl who was running the pharmacy here. So wadosi wakitoka na yeye anaenda job. So we have challenges, those are realities. And then of course we have issues in the supply chain, challenges around the, track and trace, visibility, etc., etc. I just wanted to paint for you where we are. Now, another thing of where we are input-based now in terms of how we finance our HPTs. Are we together? We are input-based, which means we purchase, the county purchases HPTs for the facilities, for example. Facilities purchase their own HPTs. Occasionally, MOH, national government, is also purchasing some other medicines for. Are we together? Yeah. So I don't know if you can see that. This is from the health facility census, just showing you how availability for essential tracer, the census was last year, right? So this is last year's data for around 12,000 something facilities that had, that responded to this. And you can see that if you look at all HPT tracer, which facilities had all the medicines, for example, required? Only 6%. This is for medicines. Only 6% of surveyed facilities had all the HPTs at the time of the survey visit. Are you seeing what we mean? There's a problem. And this is what we call what? Tracer, which are supposed to be available 100% of the time. And if you notice, the lower you go in the first one is paracetamol, and the lower you go, the lower the availability as you come to the NCDs. By the time uko hapo chini, amlodipine, insulin, nini, you can see the availability is quite poor. So we have an availability problem, stockouts. Then this is just linked to what Dr. Mwai mentioned in the morning. But it's just to show that our out-of-pocket expenditures have reduced over time. So we've made progress. But you're still quite high, and a large chunk of that is HPT costs. Ukienda kwa hospitali saa hii, what will you be told to buy? Syringe, gloves, bucket, jig, paracetamol, medicines, ndio. So a lot of what you're being told to buy outside of the system is still what? HP. Alafu lab haifanyi, so you'll be told what? Go outside, there's a lab over there that works, and then you come. Are you seeing? Yes. So it's a problem, and part of this is what we want to address. This was an attempt to show you, I don't know if it's, I got it from the gazetted list, but maybe I should have made it slightly bigger. But it's just showing you we have a bundled payment. So the first one above there is inpatient services. So we pay hospitals for all the services that you perform per day, a certain rate. So people call it per diem rate, or, you know, so which is either per day, which is the per diem rate, or case payment per case. Are we together? So we put all the services together and we reimburse you based on that. There are benefits to that, but there are also challenges to that. So for example, here in this case, the proposed for SHA is that a level 4 would be 3.5, a level 5 would be 4K, and a level 6, is it 5K or 4.5? Yeah, 5K per day. So if you're admitted for 6 days, then that's what the hospital gets paid. E5,000 includes kila kitu. So hapo ndio kuna dawa, HR, food, stima, maji, kila kitu, lab, right? And for private sector, of course, it also includes their HR costs and infrastructure costs. So that's what is called bundled. What are the sets of things I need to pay for you to give me this service? I bundle them together and I pay you, right? However, so hospitals will, let's say, and NHIF usually says 20% of the 5,000 is dawa. Yeah? So 20% of 5K is 1,000. So a facility will be paid the 1,000, first and foremost, whether or not it has the dawa. And that's why you hear NHIF has a lot of push and pull with providers. Because patients will go to Mbagathi, like I know there was a small riot in Mbagathi one time. They go there, they have been told by NHIF, do not buy dawa. We have already paid the hospital. Then the hospital says what? Out of stock. So the patients were not amused. And they were calling and complaining the call center repeatedly, right? And it caused quite a bit of a stir because they started making noise at the hospital, right? Yeah. So you see, there are issues there. Number two, I know, particularly for higher level facilities, there can be an argument of what is the 1,000 supposed to cover? Yeah, because even, so there are underpayments because it's supposed to be like an average over the patients. That's the thinking. But that's the discussion we want to have. Can we unbundle the pharmaceutical component of this and be very clear, right? And pay a hospital for what they dispense, do not pay them for what they did not. And then from those efficiency gains, can I get enhanced coverage? So that's the argument. Sorry, that was not very clear. So the current status, this is the share benefit package. I think this was mentioned. So you can see that, again, it's implicit. Dawa iko implicit. This one is in red because at the time we discussed with the team and we had proposed to do this. The ones in red are where we still have issues, and I think Dr. Mwai mentioned. There was a proposal to have mortuary services. I think that has now been dropped because of funding. Yeah. Optical services, Dr. Mwai mentioned. Sindio? Ivo. Yeah, it was there, but as at last week, it had to be dropped. Oh, they returned it? Oh, I need to check again. Yes. Yes. Under primary healthcare, correct. Yeah. So there's a bit of work to happen over the next 2 years, right? Particularly for a lot. Dental is a big issue. We have a challenge there, rehabilitative challenge, screening, outpatient level 4, 5, 6. There's a bit of an issue there. Specialized essential diagnostic, assistive devices, mortuary, and pharmacy benefit. Mental health, lab. I know they're also sitting down to also have a conversation around the packages for those. Senior, they are trying to also have that conversation, right? Assistive devices, there's a list, but we will look at the list again.
It doesn't fall under rehabilitative services?
No. The devices were, yes.
But rehab services
And now the other services, yes. They were separated out. Okay. Yeah. And then remember the principle, explicit, be clear. Are you covering one crutch or two? If I need a wheelchair, is it in or not? Sindio? Si ile mambo ya, huyu atapata na huyu Now we want to be very clear and communicate to Kenyans clearly. Is it in or out? So, of course, we know there are other work areas. The Kenya National Pharmaceutical Policy is linked to this. The essential list will be vital moving forward. I hope we have seen from the Thailand example, they call it the National List of Essential, NLEM. So some of the documents or policy directions we've been working on are going to be instrumental moving forward. Of course, we're not starting from scratch. We already know what is essential. So that's where we want to ask ourselves some questions. Medicine affordability and pricing, there was some work around that. I was also told the other day, there was a pricing even committee some time back. We will borrow from there. Then national product catalog, the one we completed, has been uploaded to the system. So the system now, you should be able to prescribe and dispense and very soon bill. Now next, once you're able to do that, then the question becomes, what am I prescribing? Because you remember that list was how many? It was what? We almost did almost 11 or 12,000 products, you remember? For the catalog, 15,000 products. So, but we are not going to pay, SHA will not pay for 15,000, Are you seeing? So the question now is, how are they in the system for other functions, but for paying, which ones among the 15,000 are you paying for? That is a question, right? Local manufacturing, hiyo tushasema. End-to-end visibility, of course, track and trace, all that work is related there. So what is this package? I know it's just the explicit list of the pharmaceuticals or HPT that you will select for the purpose of a very specific list of diseases for those who are eligible. In this case, social health insurance beneficiaries, right? You can also do a list, but you fund it through taxes and you say all Kenyans, it doesn't matter whether you're a beneficiary or not. The point is you are prioritizing, you are selecting, prioritizing, and arriving at something that you say, these dawas will be available in the facility and paid for, these ones will not. So if you're prescribed this, then you have to either use private insurance or get out of pocket. So there are many benefits to this. Of course, it enhances availability, access, and financial protection. So let's take the example of the diabetic patient, or the hypertensive patient we saw in the morning. If all my, and if you speak to patients, particularly your parents, the elderly, they will tell you one of the major complaints is, niko sawa consultation, niko sawa kwa tests. But when it comes to my monthly dawas of 7,000, like the last patient I asked, 7,000 shillings per month, I have a problem because those dawas are not available. So I have to finance. And I'm sure even you, if we ask here, si kuna mtu munanunulia wazazi dawa? Sindio? Hiyo ni kawaida siku hizi. So if those dawas were available and covered and paid for, it saves you the 7,000 shillings, right? Which is the point of UHC, financial protection. Guiding public financing, of course, we will only put, you saw the criteria for the HTA, sindio? It must be safe, it must be cost effective, sindio? Affordable, locally manufactured. You can already see the criteria coming that will be employed to determine what is in and what is out. Efficacious, etc., etc. Make the package explicit. I think this one is clear. Saizi Kenyans are not clear which dawa is available, which one is not. And kama dawa yangu iko available, how many tablets or capsules am I allowed? What is my limit for dawa? Like I think if you are in the enhanced cover, outpatient, there's a certain amount. Sindio? You can wipe it out in 1 or 2 visits, or you can spread it out over time. People need to be very clear about some of these things. Enhanced pharmaceutical management. Remember now with FIF, procurement and budgeting. Dr. Moy mentioned, that's why those laws came before. FIF, which is what counties don't like to talk about. But anyway, FIF is supposed to do what? The money remains where? So that they are able to restock. Senior? Yeah. So, and of course we know in our county system, people don't want the money to remain where? Senior? Yes. Cost, connect benefits to specific outcomes, enable prescription. This is the one I want to highlight. Prescription portability. Right now, if you go to Mbagathi, prescription, diabetic, 5 items in the prescription, you get 1 or 2. Where do you get the other 3 out of pocket? Are you able to carry that prescription from Mbagathi to KNH so that Dr. Dorothy can give you the 3? But why? Public. Yeah, if Mbagathi doesn't have the dawa, if it's 5,000 shillings, they dispense 1,000. Hiyo 4,000 kwa nini unawalipa? Why can't I carry that 4,000 with my prescription to KNH? If KNH has it, KNH makes the 4,000. That is what is called prescription portability. Can I move with my prescription to who has what? Right? Enhances compliance, of course, to reference pricing. This pricing conversation is huge, right? Whenever you're doing a package, there's always back and forth, right? There's always back and forth, as you shall see shortly. I think the discussion has started. Yeah, that you want to pay me. In fact, last week someone was asking, how can cesarean section be 30,000? And then someone asked, but kama linda mama ni how much? 5,000. Na watu wanajaa kwa laini ya linda mama. So facilities, some facilities were very happy. Low-cost private FBO are very happy with the 30,000. Right? Sasa wewe ukijaribu kwenda kwa maternity ya 300,000, so 30,000 minus 300, 270 on your pocket. Yeah? So anyway, compliance to certain pricing based on costings. Local manufacturing tumesema, and then, and by the way, saizi, we have an ongoing burden, increasing burden of NCDs. Sindio? And our infectious diseases are sort of slowly going down, excluding the outbreaks and the pandemics. So, for NCDs, what do you need to do? Modifying factors for NCDs. People must stop smoking, eat a healthy, balanced diet, exercise, weight control. Sindio? Yeah? So where do I get this smoke? I have a problem with smoking. Where do I go right now? You just go there, the doctor is telling you stop smoking. But where do I go so that I can be assisted to? Some of these services are, in other countries, those services are available in the pharmacy. BP monitoring, sugar monitoring, those are things we should facilitate the pharmacy to offer. As we speak now, vaccination is being done in pharmacies. So this is not just about HPTs, they are services. If I'm hypertensive, well-controlled, my BPs are good, my outcomes are good, why do I need to go back to the hospital, queue for 7 hours to just get CT treatment for another 2 months? Right? And then, of course, a private hospital, lazima ni consultation. Hata kama niko sawa, lazima to test. Sindio? Sindio? Are you seeing there are some efficiency gains we can gain for particular criteria of patients who don't need to go through that entire process? Can I just go to the pharmacy and I get my next batch of medicines, and then in the next review? So criteria can be prepared for that. We decongest the hospital and enable people to just, with a very specific criteria. So that's the thinking. So there are services linked to this. So this is for the TWG to develop the package, design and implementation, for the package. We might do a package. You remember there's a budget impact analysis, Sindio? And then we realize, hii kitu inahitaji nini? Mwai said We are now at expenditure of what? 500 billion? Did you say 550 or 500? 550. Is it 550 now? Yeah? Billion Kenyan shillings per annum. If we go with the proportions, NHIF has been using 20%, although in Kenya, I'm still trying to get the updated. But even if you compute to 20%, then HPTs alone are around what? 110 billion? Now, and then you start minusing the donor programs, whatever is funded. So we will have to prioritize at some point. We're able to say, okay, let's start with this. The package proceeds, but the rest will be added as we go along. Link the package to reimbursement. I think we've made it clear. If you don't have a medicine, you should not be paid for it. We pay those who have. And you can imagine if you go to the CEO and you're the pharmacy in charge and you tell them this month August, we have lost 4 million shillings, 5 million shillings because of, it's called, we call it what? The lost sales, that analysis that gives you, if you had it in stock, you would have made 4 million shillings. What do you think that CEO will do? Make sure you have the items in stock, sindio? But now it doesn't matter, hata nikuwe nazo nisipokuwa nazo bado nitali. The incentive is actually to be stocked out because you are paid and you don't use anything. Are you seeing? Yeah, so we'd rather flip it and say, okay, the incentive is do what? Stock. Sindio? Disseminate. So the process is very similar to what has been discussed under HTA. Of course, there are other, establishing a technical working group. I think that is now with the DG shortly. That should happen. Induction meeting happening next week. Training, already members are here partly. So it's already happening. Next is to develop the package. Now this develop the package is where you will see similarity with the HTA process that was highlighted. So you establish the goals of the package. What is the scope of the package? Is it pharmaceuticals only? Are you adding assistive devices? Are you adding, Ivo, that is a conversation. Program items. Are we including the HIV, TB, malaria, vaccines? How do you, so that whole conversation needs to be clear and well guided. Then select the evaluation criteria. I think we've been discussing that: safety, efficacy, cost effectiveness, local manufacturing, affordability questions, outcomes, strategic purchasing. If I use this for hypertension, what level of outcomes do I get compared to, you remember that conversation, the comparative analysis? So, so that progressively, you are paying for medicines that give you better and better outcomes and dropping the rest over time. Okay? Gather evidence, conduct budget impact. I think we've discussed that. Then you remember there was a step for deliberate and decide. So this is the HTA pretty much process of thinking through. And Dr. Tabitha made it, someone was asking me the other day, must we really do HTA for everything? And I think now it's clear. Not necessarily, and you don't have to do primary data. Some things you can just double check your secondary data, proceed, right? And then on a progressive level, pick topics for you to evaluate, something like that. I think that's what we discussed in the morning. Cost, I know this is a big one that people will wait for. Cynthia? Huh? When you say amoxil, tutalipa 10 boba capsule, 500 mg. Now the market will start paying attention, isn't it? Now stakeholders will appear. You remember the noisemakers in the morning? Yeah, they come with their interests, right? To say, no, this cannot work. 10 bob inatoka wapi? And then validation and the rest that are usual. So of course there's some challenges around this. I think we've discussed quite a bit of this. We talked about data in the morning, facility ICT infrastructure versus the health information exchange. We want to go digital, but 80% of the facilities in Kenya are level 2 and 3, of which we split public and private. How many of these are connected to power, and how many of them have internet so that they join your health information digital superhighway? Si tumesema claims kila kitu sasa itakuwa ele, and we have 15,000 facilities. So yeah, those are some challenges there. Funding, of course, governance structure for package. I think this was very well articulated by Mwai and the Ghanaian, the presentation by the Ghanaian doctor. and then high interest stakeholders. Pricing is always complicated. Even when it's clear, people will make it complicated, right? So that is the thinking around the pharmaceutical package. I want to stop there. Dr. Tabitha. Yes.
Thank you, Dr. Jared. I think now we have a clear picture, ni roadmap, reasons. Yes, what we need to do, why we need to do it, and why we are here. So, ndio tuchangamke. Are there questions? Any questions for Dr. Jared? Do you have?
I think it's for both of you. Just, I want to clarify something on the criteria for selecting an appropriate HTA, the stepwise way that you took us through, the safety, the effectiveness, the cost. It's a global standard, or like do all countries have to follow the same procedure, or how does it work? Is it standard? Okay, I think it's yours, because Jared did talk. Yeah.
Thank you very much for the presentation. I just want to ask, what are the kind of data gaps that you see would require research, like going forward, so that they can feed into the benefits package? Like what kind of research should be done going forward? Yeah.
Thank you very much for that presentation. I wanted to ask, why you calling it pharmaceutical benefit package instead of HPT benefit package? Because I remember when we did the discussion on the Heathrow, we saw how all those people all those products are linked, the devices, the medicine, and all this.
Interesting question. I'll come back to you.
Yeah, thank you, Gerard. And I think this, for me, is a more of a concern, especially to the pharmaceutical people. How come, even the structure you have there, nothing shows pharmaceutical? Is it that we are not organized to fight for ourselves, to show what we are doing? You're already saying that 20% of what is spent in a facility is pharmaceutical or HPT. But even in your structure, the one you are talking of all those services, we are swallowed in there. So how come we are not there? How come you are not here? How come you are? I also have the other document which is talking about the packages.
Yes.
We are nowhere. Why are we like that? It is a concern, because is it that we are not able to express ourselves as pharmaceutical people? Is it that our services are swallowed by others? Why would we be like this? And I know this is a major concern to the pharmaceutical people. And I wish we could come out clearly. When you talk of medical outpatient services, there's a special service called HPT, and it's captured separately. Because even in the document, it just talks of discharge drugs. Na inafika hapo. So when you are seen as an outpatient, the only mention as pharmaceutical thing is discharge drugs, which is also part of the, these are services offered. But as an outpatient, can we have something, I don't know, I don't know, where are we going wrong as pharmaceutical people? Me, that's what I'm asking myself, because if you are not in any of this, we can't identify ourselves here, isn't it? And our services are so crucial. We know that 80% of the patients, if you don't get drugs, you are not treated. Even if you are seen by the best professor, the fact is the drugs I didn't get services. So I think at that level, Gerard, we need to fight for ourselves and show the importance. The other thing, maybe the question is, where are we anchoring this pharmaceutical package? And as a colleague there has said, why are we still calling it pharmaceutical package? It should be HPT package. Where are we anchoring it in this? I'm not seeing that link. Wherever it comes, I'm not seeing it here.
Yeah, mine is also a concern on this structure. I thought you said that this structure has to be very explicit. So there's something that is not coming out clearly for me, because when you talk of specialized essential diagnostic services, it's in red on the second column.
This one.
Yes. I don't really understand what you mean. And then, because I'm also saying, okay, I'm concerned about the lab. Where is it falling? Because even medical imaging is a diagnostic service. Yeah, so it's really not coming out clear, and I need that clarification.
Yeah, thank you very much, Dr. Jared. Now, I was part of the team that was doing these costings, and there have been different versions, different variations, different processes, different EWGs. I was not in the last one, though. But one question, when we were doing input-based costing, and there was a cross-cutting area, you know, pharmacy, the cross-cutting areas.
Yeah.
Who determines the baseline costs? Because that was where the first challenge gap we have. The healthcare financing that we are with, we really spent a lot of time trying to figure out what will be our baseline costs. Some we got from KEMSA, others there was PPB, but they are not talking to each other. Then the ones which we could not get the cost, like cancer drugs amongst others, we were advised we get 3 different suppliers, get an average. So you see, there was so many variations. At the end of the day, costs were not consistent. So the question that I have, who determines the baseline cost for the country? Is it the vendor? Is it the supplier? Is it the ministry? Is it KEMSA? Because if we don't have that data, we'll forever be having this kind of.
Do you want to answer that and take a second round, or one
Yes. There are very many. Yeah, okay. Ama, there is more?
Mine, I think, is the last one.
Okay.
So on your chart, it's only talking about services. There's nowhere where you're charging like for what you've consumed, the HPTs. Then for specialized pharmacy benefits, is it the drugs for special diseases like oncology or something? Or is paracetamol included there?
All right. You want to, I go first? Or you go first with the first one on standard criteria?
Okay.
The-
Yeah, on standard criteria, there's globally, there's usually, for any guidelines that we're coming up with, are usually informed by something. And even for HTA, there's the WHO framework itself that gives a list of the things that can be considered. But countries have customized that to what is available for their country. So for example, if you're talking about use of adaptive HTA or use of equity or social, consideration of social impact, if you don't have studies that have looked at social impact for certain interventions within our country, and we know how the social issues have a serious variation, the cultural aspects of it have serious variations depending on which part of the world you are. So countries have been able to adopt and align and agree on what criteria they are going to go by. And that has been like all the stakeholders coming together and agreeing that, we are working on a pharmaceutical benefits package. This is what we need to agree on. And some countries have actually even gone further to put into their policy that if you're presenting evidence for a drug to be registered into their country, you have to also provide pharmacoeconomic evidence. I don't know if that is something that is happening in Kenya, but for some countries, like they've actually put into the guideline that, and into the policy that all the evidences that you need to provide. So the effectiveness, the cost effectiveness, the ethical issues, the equity consideration, so that when it comes to this level and we are considering to provide it in the list, we just look for information that maybe like we are querying, but already the pharmaceutical companies have done that work because they know when they're coming to Kenya to introduce that drug to Kenya, these are the requirements. And those are the things that you can actually list that you require to be provided. So it's not cast on stone, very amendable according to your country. But we learn from other people as well, whatever they've done and what we are able to adopt. So you don't want to put only 3 criteria, and there's so much more that should be considered that will give you better decisions. Yeah. Then maybe you'll respond. I wanted to comment on,
yes,
on the costing, but
yes,
maybe from a subjective and not objective perspective. So who determines cost? I remember when we were having this same training, one of the presenters shared with us the experience on, actually one of the participants, not even the presenter, one participant who was telling us the experience with adopting HTA into policy, talked about how they costed, is it Linda Mama? Like they actually did the proper evidence costing and what it would require. One of the interventions, I can't remember if it's Linda Mama. What is 6,000 shillings? Is Linda Mama 6,000? Normal delivery? 5,000. Yeah, something like that. There was something that they needed that was being reimbursed at 6,000. But when they did the costings, it actually came to 2,000 shillings. Like, to provide that service, actually, we only needed to pay 2,000 shillings for that service. So when they were very excited, oh, we are going to cost save for, our country. Look, we are moving from 6,000 to 2,000 shillings only. Wakaulizwa, tunaenda kuambia service providers nini? Tunaacha kuwalipa 6,000, tunawalipa 2,000. Who will agree to provide this service? Can you get it back to 6,000 and make sure those formulas inform that 6,000? So, yeah, that was a story that we were being given. Yes. So that's the landscape that we are in. And it just means that you'll provide all this evidence, but there's also the soft part that needs to be done. Yes. So as much as we want to provide evidence and run away from the political bit, politics still informs the decision. And the noisemakers sometimes also have a way of pushing decision makers to get what they want. That's why, as you start the HTA process, the stakeholders have to be on board. If you get to that 2,000 shillings, and they don't know where this conversation started, you're in for it. Start the conversation with them so that when you arrive at that 2,000, they are walking the journey with you. It's easier that way. Yes.
Absolutely. In fact, let me start from there. I've even remembered now, dialysis. When dialysis, we were paying now what? NHIF pays 2 sessions a week, 9,500 each. When costings were done, we could go, the actual costs were 5,500. NHIF attempted to come from 9.5 to 6.5 so that we do 3 sessions a week, which is a WHO recommendation. Do you remember the noise? Until the former president, you remember, had to, because the providers went up in arms and said, from that effective date of 6,500, your patients are not where? We are not serving patients at that rate. They will pay out of pocket. The former president had to write a directive, and you remember that conversation? I think it was 2022 at the beginning. Yeah? And he directed that all those revised costs be suspended with immediate effect. Please engage the stakeholders more. So mnaweza fanya hata hizo costing detailed, lakini you'll get somewhere, then you hit a snag. So yeah, so stakeholders, so who determines the cost? I think it needs to be a proper activity, proper input activity-based costing, evidence-based, all stakeholders on board, and ideally that should be led, of course, by MOH, Health Financing Division, but you have to include everyone in that conversation so that they own the process, they own the output. And then I will link that last question to what Dr. Lucy was asking. A lot of the gaps, in fact, from this conversation, you can see already we have some serious costing data issues. As Athanasio mentioned, we have issues between different, everybody gives you their different versions. So ideally, and you know MAPAC, Dr. Eunice, MAPAC, one of the things was we need to develop a price database where you record all these prices and you're able to arrive at a national index. That national index is supposed to guide you now, SHA. What is SHA paying? Right? So it's quite a bit. So we have serious gaps there in terms of costing data, utilization. We have a lot of questions around new interventions, medication therapy management, medication review, you know, all that, TDM services. There's a lot of questions that we do not have, you know, we need to look at and think critically through a HTA process. So there's a lot of gaps in terms of that. When it comes to the, now, so I think that answers the last and the second question. Then the issue of, yeah, there were two. Now, the question of farms, it's not that the farms are not there, right? They are bundled together with the other services. It might not be a victimization decision, but it is where many, okay, actually most countries, whenever you start an insurance system, you tend to bundle everything. Why? Because it helps you to minimize cost. So most countries, you don't start from a very highly unbundled, you know, provision of service. You tend to put everything together, ICU, 35K a day, 10 days maximum. And then that 35K, because most countries when you're starting, even Kenya, we now, we did the level 2 and 3 costings, activity-based detailed costings for level 2, 3. We have no costings ever on level 4, 5, and 6. Kenya has never done a proper comprehensive costing. So a lot of times we just engage in price negotiations, like the example I gave you for dialysis, right? The Kenya Renal, whatever, this patient association, they are very nice. I like them because they are very well organized. They come and they tell you, okay, we have come with a sample dialysis center. We see 100 patients. This is our bills for water, steam, nini. Then munaanza kucost. But you see, your data imetoka wapi? So it's because you are in a health system that health systems take time and health systems mature over time. And as you mature, you tend to now dig deeper into certain activities. So most countries, what they do, the shortcut is what? This thing is too complicated, bundle it. Tutalipa linda mama 5,000. No, 5,000 nakava nini? Let's just negotiate, we'll give you numbers, so don't worry. Unaona? But as you go along, and I think unbundling has become a recent, I think it started like 2000, the year 2000. Many countries have now tried to unbundle the medicines so that, again, make it explicit and get data and then monitor as you go. So that is a challenge. That includes lab, AIDA. Lab services tend to be bundled for the test, right? And many health systems, many insurance do not go to the details of removing, because how do you pay for the reagent or the test strip? You tend to just say malaria test. Yeah, you do an activity-based costing and you pay per test for the output. You don't go to the details of, and that has been there. So okay, how do you say this? There are different preferred payment provider mechanisms depending on the service. And you tend to balance access with cost containment, right? You're looking at how to, Dr. Nancy, unajaribu kuangalia, unasema, okay, this one, let's do this, but to contain cost, right? And then that, so like for lab, the reason lab is not, and I know lab team is also having a conversation around this, but what is usually preferred for lab is to pay per test. If it's a surgical procedure, you tend not to go to the detail of how much anesthesia was used. You just pay for the surgical procedure because it is assumed that you've done activity input-based costing and it is already factored in the cost, right? So that is why, coming to the other question now, the fourth one, that is why we chose the name, okay, so far, pharmaceutical package, because the SHA and the benefit team felt that for now, we need to limit ourselves to medicines, which is where we have an issue. We are not going to separate gloves from a nursing procedure. We will pay for the procedure costed with the surgical spirit, gloves, syringe, and whatever else was required there. You get? Because remember, you have to baby steps. Lazima uanze mahali lakini unaenda mbali. So that was a conversation. So initially, it was felt that let's limit our, and most countries start like that. You limit yourself to the medicines and some assistive devices, the crutches, whatever you need to pay that is on a fee-for-service basis, because you want to make sure the patients get certain items they must get. But what is already implied, like if you go for what? If you go for traction or some surgical procedures where you're using the surgical screws, there are other mechanisms that have already made sure the doctor has to use the screw. So we don't really need to go and unbundle and go to the level of the orthopedic screw. But yes, some institutions split, but now when it comes to a social insurer, you tend to bundle more to contain costs. Because remember, you're bringing everyone, those who can pay, those who can't pay. Kila mtu anakuja kwa hii meli. So you try to balance costs. So it's purely from that point of view. And that's why we tend to start with the pharmaceutical package. And then progressively, it eventually becomes a HPT package, right? Yeah. So it's just cost containment, access, balancing the need. Then I know we need to move. There was, so I think I've answered cost, HPT. Then there was a question of the specialized. No, I don't know. This is not, unajua nimeona watu wanasema in your chart. I want to give a disclaimer. This is not my chart. So this was borrowed from the, so this is what SHA has done for the public dissemination meeting to just illustrate. In the gazetted regulations, there is no specialized pharmacy benefit package. This one, they just wanted to highlight what has been done vis-a-vis what is still pending. So this is administrative, not the, so don't worry about the name, right? But the package, okay, and secondly, the idea, when health financing was requesting DHPT to do the package, the initial idea of why they called it specialized was, can we just drop the paracetamols and start with NCDs, renal and oncology meds, right? Things that are very high cost that we really want to make sure Kenyans are not told to go buy. Sindio? Yeah, that was the initial thinking. And then, easy paracetamol nini zikuje baada, that was the thinking, right? You know, oncology, if anything is out of stock and you're told to buy, sometimes it can be quite heavy, eh? So that was the initial thinking, and that's why the term was coined as specialized. However, the TWG will determine where to start. So don't worry about that. I think is that okay? I think I've answered data, HPT or farm, no farms. The HPT is listed, we've talked about that, and yeah. And the cost being varied and who should do the cost. So by the way, moving forward, and that's why we are really excited, Tabitha, to be here. You can see that moving forward, we are moving to a package. All services are provided in some sort of a package, which means what? Increasingly, HTA is going to be very important moving forward, because that's going to be the language. Sindio? Yeah. That's going to be the language. Yeah? I hope yes. In your eyes, I can see that I've answered the questions.
Thank you so much, Dr. Jared.
Yes.
Nancy has a comment as we switch gears.
Yes.
Thank you very much. I think I have two comments. And one is something you've mentioned, and thank you very much for your great presentation. You mentioned about portability of the HPTs across the facility, something which is very beautiful. And I just wanted to add, beyond the portability across the facilities, like when we are talking about PCNs, maybe several facilities coming together under one level 4, you may find they don't even have that medicine, because if it's within a county and they're not buying, maybe across all the facilities they don't have. So we must go to the retail chemist outside. We must and join them in the digitized system for them to be able to give what the facilities are not having. So I think that's something I wanted to comment. The other one I wanted to comment on is something Atanasio has asked. When they were costing, they were finding some prices in KEMSA, some prices in PPB.
some prices are being told to get few suppliers and do the average, and he's asking who determines maybe some of those prices. And I think beyond even what we have heard about the costing and the leadership, just giving a caveat, go back to this, there's also the aspect of our liberalized market, where it was liberalized, I think, around 1984, where it's left to the forces of market demand and supply. So when you come with your paracetamol, nobody is going to tell you put it at this. It is the market that will determine. So you will find very ranging prices at the national, and those are some of the things now we want to say, because the mechanisms that have been there, like KEMSA, to supply the public system and maybe moderate how prices become in the private sector. It's not working anymore. Sometimes you find KEMSA even has higher prices than the private market in some areas, especially when they mark up for last mile. So we want to be speaking now to the regulation of prices. So I think the national are coming from that kind of an area where the prices of medicines are determined by the market forces. That's what is the situation. Thank you.
Thank you, Dr. Nancy. So you can see that we have very many difficult conversations that we need to have. And there could be fights. Yeah? There could be fights. When you're trying to, I remember this phrase, kuna wala nyama na, when you're trying to pull out the meat from the plate, there could be fights. But if we have consistency in the processes that we decide to undertake, then slowly and with time, if the country is focused towards cost savings and actually protecting Kenyans from out-of-pocket expenditure, from the financial risk, then with time people will comply. People will start to realize that they don't have to make 100% profit or 200% profit. You don't have to import medication at X amount of money, but because in Kenya that medication is sold so much higher, you meet that price because someone will ask you, kwa nini yako ni cheap? Is it the original product, or it's fake, or it's just powder from India? Those things happen. If you worked in a pharmacy, I remember during my internship, someone would ask you, why is this one cheap? Is this one fake? Yeah, and some people just want the expensive one because maybe that's really the original one. But if you get to a point we are able to standardize prices and they speak to what the population needs are, and we increase access to medication, then we won't have to have those conversations. So we need to do an exercise before the day ends. And because of that, I've cut this slide short because it's this presentation short, because it's the exercise we're going to do. So we're going to take numbers and go into groups. And we'll make the exercise very short. Instead of selecting 10 topics per person, per group, we'll do just 5. And then we'll present on how we've selected those topics. So I want us to answer this question. How can we make sure that topics selected for HTA evaluation are policy relevant? We have a guide on how we are going to do the exercise, so don't worry about writing this down. But what I want us to remember, and you remember me asking Dr. Asare how they selected the 40 topics. And that's a good starting point. Like, if you're not able to mobilize stakeholders now, you remember the slide I showed on the highest budget impact interventions from from NHIF course. The first one was hypertensive drugs, then there's kidney, there's treatment for malaria somewhere there. So that's what they did for their country. They took the interventions that were taking up the 80% of the budget and now subjected that to HTA. And that's a process that you can undertake. Like for the pharmaceutical benefits package, what are those medications that are taking the biggest chunk of the budget that we may need to interrogate and probably come to a cost-effective price that we can then negotiate. I know there are pharmaceutical companies. There's this pharmaceutical company that provides medication for breast cancer. Which one is it? Is it Roche? Yes. Nigeria has been able to price negotiate with them. Are we price negotiating with them?
Yeah, there's a drug we have trustuzumab.
And it was based on like evidence. We generated we looked at cost effectiveness for our setting and agreed that this price actually made sense, or it's the price that they suggested that we adopted.
Actually, the push was from HTA.
Mm-hmm.
So they negotiated with Roche what would be reimbursed. So we worked backwards to get the price that KEMSA buys from Roche.
So yeah, who determined that price? Because some countries actually determine, they say this is our burden for breast cancer, we need this medication, this is our budget, we're actually able to buy this medication if you're going to give us at this price. And then people go to the negotiation table. So those are the things that we can interrogate as the pharmaceutical benefits package as DHPT. So we have work to do. We have to include our stakeholders when we are doing topic selection. So all these people, they are patient groups, civil society, the funders, policymakers, non-government organizations, academics, everyone who needs to, and we'll probably need to think about mapping out who those are if we haven't mapped them out to know. So this is just all that. So let's do an exercise. So as we turn the HTA topic into research question, we need to think about who the population is that we are targeting, what intervention we're looking at, what are we comparing that intervention with. In the morning I asked, when we're doing costings for the intervention in the benefits package, did we just cost or pull costs? Did we compare with other interventions that we should think about or we could have thought about that are cheaper? Or did we just cost what we have been providing from historically? So what are you comparing it with and what outcomes are you intending to obtain? So let's, we'll say, how many groups, how many are we? About 30. So let's have 5 groups. I think that's good enough. 6 per group, right? So we'll say 1 to 6. Okay.
1, 2,
3,
4,
5.
1, 1. Say 5.
1,
2, 3,
4,
5.
5, 6,
1,
2.
3,
5.
1.
2,
5.
5,
1, 2. Okay. So group 1s will be here. Group 2s will be here. Group